Imagine you're in that high-stakes exam, maybe an FRCS Viva. A critical medical case unfolds right in front of you. Every decision you make, well, every piece of knowledge you pull out, could genuinely save a life. That's the kind of intensity we're aiming for today.
Exactly. You know how we love to take a complex topic, grab the latest guidelines, and really distill them down? And today, we're doing just that, simulating a surgical viva focused squarely on the new ESVS 2024 Clinical Practice Guidelines for Abdominal Aortoiliac Artery Aneurysms.
Right. This isn't just about reciting facts. It's about understanding the nuances, the why, the what next. We're digging into the practical application in vascular surgery.
And the source material is top tier. The ESVS 2024 Guidelines, comprehensive, up-to-date, unbiased, synthesizing hundreds of new references since 2019.
Yeah, 474 new ones, including RCTs, systematic reviews, registry data. They offer 160 recommendations graded by strength and evidence level. It's the gold standard.
Although it is worth noting, about 70% are still based on Level C evidence or expert consensus, so still room for more research, definitely.
Absolutely. A good reminder about the evolving nature of evidence. Okay, let's dive into our case. Picture this. A 74-year-old man walks into your clinic. He's been referred because a routine ultrasound picked up an incidental finding, a 6.2 centimeter infrarenal abdominal aortic aneurysm in AAA. He says he feels perfectly fine, completely asymptomatic. What's your very first move? How do you start assessing this gentleman?
Okay, yeah, this is a classic presentation. An incidental find in an older male. The very first thing, absolutely critical, is to confirm he is truly asymptomatic. You need to actively probe, ask specific questions. Any subtle back pain, abdominal discomfort, any funny feelings in his legs that might suggest tiny clots embolizing.
Right, because even vague symptoms could change things drastically.
Exactly. The guidelines stress that intact AAAs are usually silent killers, But any symptom, however subtle, raises the alarm. It could mean it's expanding, unstable, and shifts the whole pathway from elective towards urgent.
Okay, so let's say we've thoroughly questioned him, and nope, he's genuinely got no symptoms related to the AAA. What's next on your assessment checklist? What broader health factors jump out?
Right. Next is a deep dive into his cardiovascular risk profile and his overall medical history, his comorbidities. This is vital for figuring out his overall vascular health and, crucially, his fitness for any potential intervention.
So what specific risks are you looking for?
Number 1, smoking. Is he a current smoker? An ex-smoker? How much for how long? Smoking is just huge for AAA's prevalence, growth, rupture risk. The guidelines even mention the drop in smoking rates is linked to lower AAA prevalence. It's massive.
Makes sense. What else in the cardio realm?
And the usual suspects. Hypertension, is it well controlled? Hyperlipidemia, what are his cholesterol levels? Is he on a statin? Diabetes, these are all part of the picture. And the ESVS guidelines are really clear here. Aggressive cardiovascular risk management is a Class I recommendation for all AAA patients. Doesn't matter the size, whether you repair it or not. Everyone gets risk factor management.
Got it. Cardiovascular risk factors nailed down. What other medical conditions are really important when you're thinking about potential surgery down the line?
Okay, so beyond the cardio risks, we need a full inventory of comorbidities that affect operative risk. I'm specifically asking about coronary artery disease. Has he had a heart attack, angina, stents, bypass surgery? What about heart failure? Any signs or symptoms? And very importantly, his lungs. Does he have COPD, asthma, chronic bronchitis? Respiratory function is key for recovery.
And kidneys, you mentioned those earlier.
Yes, absolutely. Chronic kidney disease, CKD. We need to know his baseline kidney function. The guidelines specifically highlight creatinine clearance below 60 mmHg or serum creatinine over 170 micromoles per liter as predictors for renal complications after repair. These things directly impact his operative risk profile.
So we're building a picture of his major organ systems. How do you quickly assess his general physical fitness without necessarily sending him for lots of tests straight away?
A really useful quick gauge is his functional status, often measured in MET's metabolic equivalence. It's a simple question. Can he, say, climb 2 flights of stairs without getting excessively breathless, or walk briskly for a short distance? If he can manage around 4 METs or more, that suggests reasonable cardiac reserve. He might not need immediate invasive cardiac testing, but if his functional capacity is poor, less than 4 METs, or he has multiple clinical risk factors, then yes, a more thorough cardiac workup is definitely needed before thinking about repair.
That's a practical approach. What about family history? Does that play a role here?
Oh, definitely. It's highly relevant. AAA has a strong genetic component. Heritability is estimated around 70%. So I'd ask, anyone else in the family, especially parents or siblings, had an aneurysm? Any sudden unexplained deaths in the family that could point towards an underlying genetic issue, maybe a connective tissue disorder like Marfan or Ehlers-Danlos, which would significantly change how we manage things. And I'd also quickly ask about any other aneurysms he might know about, like in his legs, behind the knee, or importantly in the iliac arteries.
Okay, excellent overview. So let's recap. 74-year-old man, asymptomatic, incidental, 6.2 centimeter infrarenal AAA found on ultrasound. We've got a good handle on his history and risk factors. You mentioned the ultrasound finding. Now, what are the absolutely essential investigations we need to order now? To confirm that diagnosis, yes, but more importantly, to really plan for a potential repair.
Right. The next step, and it's crucial for planning, is computed tomography angiography, a CTA scan. This is a Class I recommendation.
Why the CTA? The ultrasound gave us the size. What extra detail does the CTA provide that's so critical for planning, especially if we're thinking about endovascular options?
Well, ultrasound is great for screening and surveillance, no doubt. But for planning repair, especially EVA, CTA gives us that detailed three-dimensional view. It allows for really precise measurements, and the guidelines are quite specific here. They recommend using dedicated post-processing software, placing the calipers consistently, always orthogonal, perpendicular to the aortic central line.
Why such emphasis on measurement consistency?
Because it matters. Different methods measuring outer wall to outer wall versus inner lumen, or using ultrasound's leading edge method can give you differences of 3, 4, even up to 6 millimeters. And when your threshold for repair is 55 millimeters, that difference is huge. It can literally be the difference between operating and watching. So consistency within a unit is absolutely key.
Makes sense. So you get the CTA scan back. What specific anatomical features are you laser focused on when you're reviewing those images, thinking about suitability for repair, particularly EVAR?
Okay, when that CTA comes up, my eyes go straight to a few key areas, especially for EVAR planning. First, the proximal aortic neck. That's the bit of normal aorta just below the renal arteries where the top of the stent graft needs to seal. I'm measuring its length, precisely need enough length for a good seal. Its diameter standard EVAR devices usually go up to about 32 millimeters. It angled sharply. Is there a lot of calcium or thrombus lining the neck? All these affect the seal quality and durability.
Right. The seal is everything for EVAR.
Yeah.
What else?
Second, the iliac arteries. These are the access routes and the distal landing zones for the stent graft limbs. So are they wide enough to get the device through? Are they too diseased or narrowed? Are they excessively twisty, tortuous? We need suitable caliber and length for the graft limbs to land securely. And a really important point here is preserving pelvic perfusion. You ideally want to keep at least one internal iliac artery open to avoid disabling buttock claudication or worse, pelvic ischemia. So we assess the common and external iliacs, but also the internal iliacs very carefully.
Anything else on the CTA checklist?
Yeah, we also look at the access vessels themselves, the femoral arteries in the groin. Are they big enough for the delivery sheaths? Any significant disease there? Then quickly check the main visceral arteries, renals, mesenteric arteries. Are they patent? Any accessory renal arteries we need to worry about? Also look for any other aneurysms lurking elsewhere, maybe higher up in the aorta or in the visceral arteries themselves. And finally, assess the amount of atheroma or plaque burden in the aorta. A really shaggy aorta increases the risk of showering clots during manipulation. Oh, and rare things like venous anomalies that might complicate open surgery.
That's a really detailed roadmap from the CTA. Okay, we've got the anatomy sorted. What about checking the patient's physiological readiness for a major procedure? Any further preoperative workup needed beyond the history and basic functional assessment?
Yes, absolutely. We need to formalize the cardiopulmonary and renal risk assessment. For cardiac risk, the first check is for active cardiac conditions, things like unstable angina, recent MI, decompensated heart failure. If any of those are present, they need sorting out by a cardiologist before any elective AAA repair.
Okay, and if no active issues?
If no active issues, then we look at the clinical risk factors: age, history of ischemic heart disease, heart failure, previous stroke, renal dysfunction, diabetes, and combine that with the functional capacity we talked about, the METs. If he's got good functional capacity, 4 METs or more, and few risk factors, generally no further invasive cardiac testing is needed. But if he's got poor functional capacity or multiple risk factors, then yes, further non-invasive testing, maybe even cardiology consultation is warranted. Crucially, though, the guidelines state that routine invasive coronary angiography just for pre-op risk assessment is not recommended. That's a Class 3 recommendation.
Good clarification. What about lungs and kidneys?
Pulmonary risk. We look for pre-existing COPD, signs of heart failure again, maybe low serum albumin. And smoking cessation is strongly pushed. It really reduces respiratory complications and mortality after both EVAR and open repair. It's critical. Renal function. We measure serum creatinine and calculate the estimated glomerular filtration rate, the EGFR. That's ASI recommendation. If the EGFR is severely impaired, say below 30 mmol/min, 1.73 milliliters, then referral to a nephrologist is recommended preoperatively. And for anyone with kidney issues, good hydration is key, especially if they're getting ID contracts for the CTA.
And nutrition. You mentioned albumin.
Yeah, nutritional status via serum albumin. If it's very low, suggesting severe malnutrition, that should ideally be addressed and corrected before elective surgery. And one last point, routine screening for asymptomatic carotid stenosis before AAA repair is not supported. But if they've had recent symptoms from carotid stenosis, like a TIA or minor stroke within 6 months, then that needs managing first.
Okay, crystal clear. So back to our 74-year-old man with the 6.2 centimeter infrarenal AAA. Based purely on that size, what do the ESVS guidelines say about the threshold for elective repair in men? And how does it differ for women? Is he automatically a candidate?
Yes. Based on size alone, he absolutely is. That 6.2 centimeter puts him clearly above the recommended threshold. For men, elective repair is generally considered for asymptomatic AAAs that are equal to or greater than 5.5 centimeters in diameter.
And for women?
For women, the threshold is lower. It's equal to or greater than 5.0 centimeters.
Why the difference? Why operate on women at a smaller size?
It comes down to risk. Studies have shown that women tend to rupture their aneurysms at smaller diameters compared to men. This might be related to their generally smaller body size, smaller baseline aortic diameter, maybe different biomechanical properties of the aortic wall. So the lower threshold reflects that higher rupture risk at smaller sizes.
And the guidelines are quite firm on not operating below these thresholds if the patient is asymptomatic and the AAA isn't growing rapidly.
Absolutely. That's a Class 3 recommendation, meaning it's not recommended. Operating on small, stable AAAs carries the risks of surgery without a clear benefit, as the annual rupture risk below those thresholds is very low, certainly lower than the operative mortality for elective repair.
Okay. What if you had, say, a 5.2 centimeter AAA in this man, but on serial scans over the last year, it had grown by 12 millimeters? Does that change the picture?
Yes, significantly. Rapid growth, which the guidelines generally define as 10 millimeters per year or more, is an independent indication for repair, even if the aneurysm hasn't yet reached the absolute size threshold. The first step, if you suspect rapid growth, is actually to remeasure carefully, maybe get another scan soon, just to rule out measurement error, because that can happen. But if confirmed, that rapid expansion suggests the aneurysm wall is unstable, under stress, and at higher risk of rupture. So yes, rapid growth triggers consideration for repair. Similarly, if a patient develops symptoms clearly attributable to the AAA, like that new onset back or abdominal pain, or signs of distal emboli, even if it's not technically ruptured yet, that also warrants urgent investigation and usually repair after a short period of rapid optimization.
Makes sense. Now, for those patients with smaller AAAs, below the threshold, not growing fast, maybe deemed unfit for repair for other reasons. What does best medical management actually involve? Are there any drugs that can actually slow down the aneurysm growth?
That's a really important area. For smaller AAAs or for patients unfit for repair, the focus is on aggressive cardiovascular risk factor management. This is a Class I recommendation. It's not about shrinking the aneurysm, but about improving their overall cardiovascular health and potentially reducing rupture risk indirectly.
So what does that entail specifically?
It includes several key things. Smoking cessation. Absolutely paramount. Strong recommendation. We need to offer help, support, nicotine replacement, whatever it takes. It slows AAA growth and reduces rupture risk. Blood pressure control. Target systolic BP, typically below 140 mmHg, maybe even 130 in some guidelines. Good control is vital. Statin therapy. High-intensity statins are recommended. They improve endothelial function, reduce inflammation, and have shown some survival benefits after AAA repair, besides lowering cholesterol. Antiplatelet therapy. Usually continued if they're already on it for other reasons, like coronary disease, limited evidence for stopping it before repair. Lifestyle advice, encouraging regular exercise, a healthy diet. Standard cardiovascular health advice.
Okay, but what about drugs specifically targeting AAA growth? Things like doxycycline or certain blood pressure meds like ACE inhibitors or ARBs. Any proven benefit there?
This is a key point the guidelines address very clearly. Currently, there are no proven pharmacological treatments that reliably and effectively slow down AAA growth or prevent rupture. Various drugs have been studied: doxycycline, certain antibiotics, ACE inhibitors, ARBs like telmisartan, even fibrates, but none have shown consistent, clinically significant benefit in large trials. So medical management is all about managing the patient's overall cardiovascular risk, not directly treating the aneurysm size itself. That's a really important distinction.
Right, good to clarify that expectation.
Mm.
Okay, so our 74-year-old patient does qualify for repair based on size. Let's explore the treatment options. Broadly, it's open surgical repair, OSR, versus endovascular aneurysm repair. How do you start thinking about which approach is best for this specific patient?
Okay, this is the core decision for elective repair. It's a complex choice, really needs to be individualized. We weigh up patient factors, the specific anatomy of their aneurysm and their overall surgical risk. But it's fair to say that over the last couple of decades, EVAR has become the preferred first-line treatment modality for most patients with suitable anatomy.
What drives that preference for EVAR in most cases? What are the main advantages?
The big driver is the significantly lower perioperative mortality and morbidity, especially the 30-day mortality. For elective infrarenal AAA repair, large studies and registry data show mortality after EVAR is around 0.7% for men, maybe 2.2% for women. Compare that to OSR, which is closer to 3.4% for men and maybe 5.6% for women. That's a substantial difference in early risk.
Wow, yeah, that's quite a difference.
Plus, EVAR typically involves shorter hospital stays, less time in intensive care, quicker return to normal activities, no big abdominal incision. So it's much less physiologically stressful in the short term. Given these benefits, EVAR is often the preferred route, particularly if the patient's anatomy is suitable and maybe their estimated life expectancy is less than, say, 10 years.
Less than 10 years. Why that time frame specifically?
Well, it relates to the main drawback of EVAR, which is its long-term durability. EVAR relies on the stent graft sealing against the native aorta, and over time that seal can degrade, the aneurysm sac can repressurize, components can migrate or fracture, leading to late complications like endoleaks or even a rupture. This often necessitates secondary interventions, sometimes multiple ones, over the patient's lifetime.
Okay, so that brings us to open surgical repair. If EVAR has lower immediate risks, why is OSR still a crucial option? Who is it best suited for?
OSR is still absolutely vital, and in certain situations, it's actually the superior choice. Its main advantage is durability. A well-performed open repair with a sewn surgical graft is generally considered a more permanent fix with a much lower rate of late aneurysm-related complications and reinterventions compared to EVAR over the long term.
So who are the patients where you'd strongly favor OSR?
It's primarily favored for younger, fitter patients who have a long life expectancy ahead of them. For them, the long-term durability of OSR outweighs the higher upfront surgical risk. Also, OSR is the necessary choice for patients whose aneurysm anatomy is unsuitable for achieving a safe and durable seal with an EVAR device, things like a very short, angled, or wide proximal neck. And finally, patients with certain connective tissue diseases like Marfan syndrome, where the aorta itself is inherently weak, OSR is often preferred because sewing a graft might be more reliable than relying on friction and radial force for a seal.
Got it. Let's dig into EVAR suitability a bit more. You mentioned the proximal neck and iliacs from the CTA. How important is it to stick strictly to the manufacturer's recommendations, the instructions for use, or IFU, for the specific stent graft device?
Sticking to the IFU is paramount for elective EVAR. The guidelines are very clear on this. They explicitly advise against performing EVAR outside the manufacturer's IFU in the routine elective setting. That's a Class 3 recommendation.
Why so strict? Surgeons often push boundaries, don't they?
They do, but the rationale here is safety and predictable outcomes. The IFU criteria define the anatomical range, neck diameter, length, angle, iliac axis diameter, etc., within which the device has been rigorously tested and shown to perform reliably in clinical trials. Going off-label or outside the IFU significantly increases the risk of immediate complications like poor seal, graft migration, and more importantly, late failure, endoleaks, and the need for reintervention or even rupture.
Any examples of why this is so crucial?
Well, the guidelines actually mention the cautionary tale of the Nelix device, the endovascular aneurysm sealing, or EVAR system. It was a novel concept, filling the aneurysm sac around the stent graft with a polymer. It looked promising initially, but long-term data revealed unacceptably high rates of late failure and complications, leading to its recall. It really highlights the danger of adopting new technologies without robust long-term evidence, especially when going outside proven parameters. Patient safety has to come first. Use devices with proven durability, ideally with 10 years of follow-up data.
A sobering reminder. Okay, what about the technical side of open repair? What are the key considerations there? Incision, graft type.
For OSR, the standard approach is usually a midline laparotomy, offering good exposure. Alternatives like a transverse subcostal or left retroperitoneal approach exist, depending on aneurysm extent and surgeon preference, but outcomes seem similar. Graft choice is typically a textile polyester graft, like Dacron. There's no strong evidence that one specific material or type, like woven versus knitted, is definitively superior. For standard infrarenal AAAs, clamping the aorta below the renal arteries is the norm. Reconstruction of the left renal vein, if it needs dividing for exposure, might be considered.
And what about preventing incisional hernias after that big midline cut?
That's a common long-term issue. The guidelines suggest that prophylactic use of mesh reinforcement when closing the midline laparotomy should be considered. There's good level A evidence that it reduces the risk of developing an incisional hernia later on.
Good practical point. Are there any general perioperative things that apply across both EVAR and OSR? Anesthesia, blood loss, clot prevention?
Yes, several common principles. For anesthesia, especially in elective EVI, locoregional techniques like spinal or epidural anesthesia can be considered instead of general anesthesia. Some evidence suggests this might reduce procedure time, ICU stay, and overall hospital stay. For blood loss, particularly during OSR, intraoperative cell salvage collecting and retransfusing the patient's own lost blood should be considered to minimize allogeneic transfusions. That's a Class TIA recommendation. Anticoagulation. Systemic heparin is standard practice before aortic cross-clamping in OSR, or at the start of EVAR, usually guided by ACT measurements, though in rupture scenarios, controlling the bleeding comes first. And thromboprophylaxis, preventing VTE, blood clots in the legs or lungs, is crucial. All patients deemed at risk should be considered for prophylactic measures like heparin injections and compression stockings.
Great overview. Now, our case was an infrarenal AAA, relatively straightforward anatomy below the kidneys. But what about the more challenging ones? Juxtarenal, pararenal, thoracoabdominal aneurysms, where the aneurysm creeps up towards or involves the renal and visceral arteries. How do you define those?
Right, these are the complex AAAs, where a standard infrarenal stent graft or simple infrarenal clamp for open surgery won't work because there's no healthy aortic neck below the kidney arteries. The definitions relate to which arteries are involved. Juxtarenal. The aneurysm extends right up to and may involve the origin of at least one renal artery. There's basically no infrarenal neck. Pararenal. The aneurysm involves the origins of the renal arteries, but the aorta below the next major branch, the superior mesenteric artery, SMA, is relatively healthy. Paravisceral, or suprarenal. The aneurysm involves the renal arteries and the SMA origin, but spares the celiac artery origin. Type VI thoracoabdominal, TAA. This is the most extensive type confined to the abdomen, involving the origins of all the major visceral branches, renal, SMA, and celiac arteries.
Okay, so significantly more complex anatomy. Are the size thresholds for repairing these complex AAAs the same as for infrarenal ones?
Generally, yes. The guidelines suggest elective repair for complex AAAs may be considered at equal to or greater than 5.5 centimeters in men and 5.0 centimeters in women, similar thresholds to infrarenal AAAs. However, the decision-making is much more nuanced here because the repair itself, whether open or endovascular, is significantly more complex and carries higher risks, patient fitness, and the specific anatomical challenges weigh much more heavily in the balance.
So how do you choose the treatment strategy for these complex cases? Right. When do advanced endovascular techniques like fenestrated or branched EVAR, FEVAR-BFAR, come into play?
This is where treatment really needs tailoring. For complex AAAs, FEVAR or BVAR are major advancements. These are custom-made stent grafts with holes, fenestrations, or side tubes, branches, precisely positioned to align with the patient's renal and visceral arteries, allowing the main graft to seal higher up while maintaining blood flow to those critical organs. The guidelines suggest FEVAR-BVAR should be considered and potentially offer benefit, particularly in patients with high surgical risk who might not tolerate complex open surgery, provided their anatomy is suitable for these devices. Class 3, Level C.
Fenestrations versus branches, is there a difference?
Generally, fenestrations, holes reinforced with wire, are used when the target artery origin is quite close to where the main graft fabric will lie. Branches, short side stents extending from the main graft, are used when there's a bit more distance between the main graft and the artery origin, often seen in more expensive TAAs. Image fusion technology during the procedure is also recommended to help with accurate placement and reduce radiation and contrast dose.
What about open surgery for complex AAAs? Is it still an option?
Absolutely. For patients with complex AAAs who are at standard surgical risk, OSR remains a very important option, particularly if they are younger and fitter. It often involves clamping higher up, sometimes above the renal arteries or even higher, making it technically demanding, but it offers that long-term durability. The guidelines state that for standard risk patients, OSR or EVAR should be considered based on fitness, anatomy, patient preference, and local expertise, class I, level C. Sometimes a simpler open repair with an anastomosis just below the renals, if feasible with short clamp times, might be preferable in fit patients even with a short neck. Supracoeliac clamping should be avoided if possible due to higher risks.
You mentioned the caution around new devices for standard EVR. What about novel techniques for complex repairs, like using parallel grafts or chimneys or devices like the old Nellick system?
The guidelines maintain a very cautious stance here, too. Techniques like using parallel grafts alongside the main stent graft, chimneys, snorkels, periscopes, or newer concepts like endosuture aneurysm repair or in situ on-table creation of fenestrations are explicitly not recommended for routine clinical practice. Class 3, level C. Why? Because the long-term data on their durability, failure modes, and overall effectiveness compared to established OSR or custom EVAR is still lacking or concerning. These techniques should really be confined to ethically approved clinical trials or registries until we have robust evidence. The principle is, don't experiment on patients outside of controlled evaluation, especially when established, albeit complex, options exist.
Okay, that's clear. Let's switch gears to complications. No surgery is risk-free. What are the main complications we need to anticipate after AAA repair, both early and late, distinguishing between OSR and EVR?
Right, complications are a reality. Early complications, typically within the first 30 days, can include things common to major surgery: bleeding, myocardial infarction, heart attack, stroke, respiratory failure, acute kidney injury, and specifically related to the AAA repair itself: colonic ischemia, bowel injury due to reduced blood flow, limb ischemia. The guidelines note that many of these major systemic complications are generally more frequent after OSR compared to EVAR, reflecting the greater physiological insult of open surgery.
What about really severe early complications like abdominal compartment syndrome?
Yes. Postoperative abdominal compartment syndrome, ACS, is a life-threatening condition where pressure builds up inside the abdomen, impairing organ function. It's a particular concern after repair of ruptured AAAs, often linked to massive fluid resuscitation or bleeding. Initial management involves non-surgical steps, optimizing ventilation, sedation, pain relief, perhaps neuromuscular blockade, gastric decompression. But if ACS develops and pressure remains high despite these measures, then urgent decompressive laparotomy, surgically opening the abdomen to relieve the pressure, is indicated. That's a class I recommendation.
Got it. Now moving on to lead complications, especially those specific to EVA. Endoleaks are the classic example. Can you break down the different types and why they matter?
Sure. Endoleaks are basically persistent blood flow into the aneurysm sac outside the stent graft after EVA. They signify that the aneurysm isn't fully excluded and might still be pressurized. They're classified by the source of the flow, types I through V.
Which types are the most worrying?
Type 1 endoleaks are the most dangerous. This means there's a leak at the top, type 1A, proximal seal, or bottom, type 1B, distal seal, attachment sites of the stent graft. It means the graft isn't properly sealed against the artery wall. These carry a very high risk of aneurysm expansion, and subsequent rupture estimates suggest 60–80% of post-EVAR ruptures are associated with type 1 endoleaks. They demand urgent correction.
Urgent correction, what does that involve?
It often requires further endovascular procedures, placing extension cuffs, reinforcing the seal with larger balloons or specialized stents, sometimes even using fenestrated or branched devices if the initial landing zone failed. In some cases, if endovascular options fail or aren't suitable, conversion to open surgery with stent graft explantation might be necessary, although that's a major undertaking. Class I, level C. Even potential compromise of the sealing zones warrants close watching or preemptive treatment.
Okay, type 1 is bad news. What about the others?
Type 3 endoleaks are also high risk. These result from a failure in the stent graft itself, either component separation or a tear in the graft fabric, type 3B. Like type 1, they represent a direct communication between aortic pressure and the sac, carrying a high rupture risk and requiring urgent correction. Class I, level C. Sometimes they can be tricky to spot definitively on CTA alone. Type 2 endoleaks are the most common type. This is retrograde flow into the sac from collateral branches like lumbar arteries or the inferior mesenteric artery that were covered by the graft. These are generally considered more benign as the pressure transmission is indirect. The usual management is surveillance with regular imaging.
So you just watch type 2 endoleaks?
Initially, yes, unless the aneurysm sac continues to grow significantly, for a 5 millimeters, or the patient develops symptoms. If sac growth occurs with a type 2 endoleak, then treatment is usually recommended, typically involving embolization of the feeding collateral vessels, either via catheter techniques or sometimes laparoscopic open surgical ligation. Type 4 endoleaks are related to graft porosity and are rarely seen with modern devices, considered transient and benign. Type 5 endoleak, or endotension, is defined as continued aneurysm sac expansion without any visible endoleak on standard imaging like CTA. It's rare but concerning because it can still lead to rupture. It requires further investigation, maybe with different imaging like MRA or even PET scan, to look for an occult endoleak or underlying low-grade infection. Class B IM level C. Management might involve relining the existing stent graft or potentially conversion to OSR.
That covers endoleaks well. What about other significant late complications that can happen after either EVI or OSR?
A really feared one is aortic graft stent graft infection, AGI. Although rare, it's devastating, with high morbidity and mortality. Management requires a multidisciplinary team approach in high-volume centers. It often involves prolonged, sometimes lifelong antibiotic therapy, especially after EVAR infection where complete removal is difficult. Surgical options usually involve attempting complete explantation of the infected graft material and then restoring flow either via extra anatomic bypass, routing grafts through undetected tissue planes, or in situ reconstruction with antibiotic-soaked grafts or biological conduits, class CAA level C. A crucial point. If a patient with a known graft presents later with gastrointestinal bleeding, you must suspect a graftenteric fistula or erosion, which is a surgical emergency requiring prompt assessment, class 1 level C. Para-anastomotic aneurysms can develop years after OSR, right next to the suture lines. Infection should always be considered as a possible underlying cause, class Psi level C. If non-infectious, endovascular repair is often preferred if feasible, class CI level C. Sexual dysfunction is unfortunately common, both pre-existing and new onset after repair, due to nerve disruption or altered pelvic blood flow. Patients distressed by this should be referred to specialized teams for support and management, class Psi level C. And occasionally, thrombus can form inside the stent graft itself. If asymptomatic and just mural thrombus, vigilance might be enough. If it's causing symptoms or looks like it's evolving, then intervention or escalating anticoagulation might be needed, class IB level C.
Okay, that's a comprehensive look at complications. Let's talk about follow-up. Once the patient has had their repair, how do you monitor them long-term? Does it differ significantly between EVAR and OSR?
Yes, the surveillance protocols are markedly different, reflecting the different long-term risks. For patients after EVAR, the guidelines recommend lifelong imaging surveillance, class Y level C. This is essential to detect those late complications we just discussed, endoleaks, graft migration, component failures, sac expansion before they lead to rupture.
Lifelong imaging, what does that typically involve?
The standard protocol is usually a CTA scan at 1 month post-op, then again at 12 months. After that, if everything looks stable, no endoleak, sac shrinking, or stable, surveillance continues, often annually. For stable patients after the first year, duplex ultrasound, DUS, may be considered as an alternative to repeated CTAs to reduce cumulative radiation exposure and contrast load, although CTA remains the gold standard if issues are suspected. Class IBIB level C.
Is there any scenario where you might stop EVAR surveillance?
Possibly. The guidelines suggest surveillance may be discontinued in very elderly, frail, or dependent individuals who are clearly not considered candidates for any further elective secondary interventions, even if a problem is found. It's a pragmatic decision based on overall patient status and goals of care, understanding they might still be treated for acute symptoms if justified. Also, if significant aneurysm sac shrinkage, 5 millimeter, is seen early on, within 1-2 years, that's a good prognostic sign, and some protocols might allow for less frequent imaging thereafter, but lifelong follow-up is still the general recommendation.
Okay, lifelong vigilance after EVAR. What about after open surgical repair, OSR? Is it the same intensity?
No, it's quite different. For post-OSR surveillance, the guidelines state there is no high-level evidence to support routine, regular post-operative imaging surveillance, class 3.
Really? No routine scans after open repair?
Correct. The rationale is that major late complications directly related to the graft itself, like anastomotic rupture or graft infection, are much rarer after OSR compared to the device-related issues after EVAR. While para-anastomotic aneurysms can occur years later, and patients remain at risk of developing new aneurysms elsewhere, the yield of routine screening for these in all post-OSR patients is considered low. However, that doesn't mean no follow-up. Clinical review is still important. And the guidelines do suggest it's reasonable to consider some form of imaging surveillance, maybe ultrasound or CTA every 5 years or so, although evidence is weak, specifically for those post-OSR patients who would be fit for further treatment if a new or recurrent problem, like a paraanastomotic aneurysm, were detected. But routine annual imaging for everyone is not recommended.
That's a very important distinction in long-term management. Okay, we've covered the standard scenarios quite thoroughly. What about tailoring treatment for specific patient groups or aneurysm types? How do the guidelines adapt for, say, women, younger patients, or those with infected aneurysms?
These are really important nuances where a one-size-fits-all approach doesn't work. For women, as we discussed, the key differences are the lower repair threshold, 5.0 centimeters versus 5.5 centimeters for men, due to their higher rupture risk at smaller sizes, and unfortunately, they also tend to have higher perioperative mortality and complication rates for both OSR and EVAR compared to men, even after adjusting for other factors. So the risk-benefit discussion needs careful consideration. For younger patients, say under 60, who are otherwise fit, open repair, OSR, may be preferred, Class I recommendation in some contexts. Why? Because of its superior long-term durability. Given their longer life expectancy, the likelihood of needing multiple reinterventions over decades with an EVAR device becomes a significant concern, potentially tipping the balance towards the more durable upfront open procedure despite its higher initial risk.
And infected aneurysms, you mentioned them briefly. How are they managed?
Infected AAAs, sometimes called mycotic aneurysms, though often bacterial, not fungal, are a completely different beast. They're relatively rare but extremely dangerous, often presenting acutely with pain, fever, sepsis, or even frank rupture, nearly half present ruptured. They tend to expand rapidly. The key principle here is that prompt surgical treatment is recommended irrespective of aneurysm size, Class I, Level C, due to that very high rupture risk. Management should be in high-volume vascular centers with a multidisciplinary team, Class I, Level C.
What does surgery involve for an infected AAA? Can you use EVAR?
The traditional gold standard has been OSR with complete excision of all infected tissue and then reconstruction, often using extra anatomic bypasses through clean tissue planes, or sometimes in situ reconstruction using antibiotic-soaked prosthetic grafts or biological grafts like cryopreserved homografts or femoral veins. This is combined with prolonged targeted antibiotic therapy. EVAR is more controversial in active infection, as placing a foreign body, the stent graft, into an infected field is generally avoided. However, the guidelines acknowledge that EVAR might be considered in selected cases, Class 3, Level C, perhaps in very fragile patients unfit for major open surgery, or potentially as a bridge to stabilize a rupture while infection is treated if it's combined with aggressive, long-term, possibly lifelong antibiotics. But OSR with debridement remains the mainstay if feasible.
Okay. What about inflammatory AAAs? Are they treated differently?
Inflammatory AAAs are another distinct subtype, characterized by marked thickening of the aneurysm wall and dense surrounding fibrosis, often encasing nearby structures like the ureters. They can be symptomatic with pain, weight loss, raised inflammatory markers. The size threshold for repair is generally the same as for standard degenerative AAAs, 5.5 centimeters, Class Y Level C. However, EVAR is generally preferred over OSR if the anatomy is suitable, Class 3 Level C. Open surgery can be technically very challenging due to the dense adhesions, hostile abdomen, whereas EVAR avoids dissecting through that inflammatory tissue. EVAR has shown lower 30-day mortality and fewer major complications in this group. Lifelong surveillance and sometimes ongoing immunosuppressive therapy might be needed.
Good points. And what if the patient has significant aneurysms in their iliac arteries as well?
Concomitant common iliac artery aneurysms, CIAs, are quite common alongside AAAs. They should generally be considered for elective repair if their diameter reaches equal to or greater than 4.2 centimeters, Class C OA. The critical technical point when repairing combined AAA and CIAA, especially if both sides are involved, is to try and preserve perfusion to at least one internal iliac hypogastric artery. Sacrificing both internal iliacs significantly increases the risk of debilitating buttock claudication, sexual dysfunction, and potentially serious pelvic or colonic ischemia. Techniques like iliac branch devices or surgical bypasses to the internal iliacs might be needed.
And patients with active cancer, does that change AAA management?
Generally, the indication and size threshold for AAA repair are no different for patients with cancer compared to those without, Class 3 Level C. However, the timing and strategy might change. For patients with large or symptomatic AAAs who also need cancer treatment, a staged approach is often recommended. If the AAA needs fixing first, EVAR is usually preferred, Class D or Level C, as it allows for quicker recovery and minimizes delay to starting their cancer therapy. Prolonged VTE prophylaxis up to 4 weeks should also be considered in these patients post-op due to the combined risk from surgery and malignancy, class D or L level C.
Finally, what about patients where you suspect an underlying genetic cause, like Marfan or vascular Ehlers-Danlos?
If there are features suggesting a genetic link, like very early onset AAA, a strong family history, characteristic physical features, then formal genetic evaluation is recommended, class I, level C. Management of these syndromic aneurysms is highly specialized, often involving multidisciplinary teams in dedicated centers due to the challenges of fragile tissues and associated risks. For vascular Ehlers-Danlos syndrome, VEDS specifically, treatment with the cardioselective beta blocker ciloprolol 400 mg has been shown to be associated with a significant reduction, threefold, in arterial rupture events and is recommended. Surgical or endovascular repair in VEDS is particularly high risk due to vessel fragility.
This is clearly a field with very complex decisions, significant risks, and major long-term consequences for patients. How much emphasis do the guidelines place on involving the patient in these decisions? What about shared decision-making?
That's a really crucial aspect, and shared decision-making, SDM, is highlighted as a core principle throughout the guidelines, especially for elective AAA repair. It's defined as a process where patients and their clinicians work together, evaluating the evidence, discussing the treatment options, including surveillance as an option, and considering the patient's own values, preferences, and goals to arrive at a decision.
Why is STM so important here?
Because these are often major, irreversible surgical treatments with potentially significant impacts on lifestyle, quality of life, and longevity. For large AAAs, where repair is generally recommended, patients need to understand the trade-off, the risks of surgery versus the risk of rupture. For smaller AAAs, they need to understand the low risk of rupture versus the risks of elective repair. For borderline cases or when choosing between EVAR and OSR, patient preferences regarding recovery time versus long-term durability and reintervention risk are paramount. Effective SDM requires providing patients with high-quality, unbiased, understandable information. The guidelines actually caution that online sources are often poor quality and difficult to understand, and they include a dedicated section with simplified information for patients that was developed with patient input. It's about empowering the patient to participate meaningfully in the decision.
Is STM always applicable? What about emergencies?
Good point. The guidelines note that SDM, in its formal sense, is generally not applied in the context of ruptured AAA. The emergency setting, often with severe pain, hemodynamic instability, and altered mental state, usually precludes a detailed, collaborative decision-making process. Decisions there have to be made rapidly based on clinical urgency.
We've covered a huge amount of ground, drawing heavily on these extensive guidelines. But science is always evolving. Do the guidelines acknowledge areas where the evidence is still lacking or where future research is needed? What are some of the big unanswered questions?
Absolutely, and it's commendable that the ESVS is transparent about this. They dedicate sections to discussing limitations and future directions. One major theme is evidence gaps. As we mentioned, a lot of recommendations are still based on lower-level evidence, level C, or expert consensus, particularly in areas like complex AAA management or rare aneurysm types. They also highlight that most of the evidence comes from studies in Europe and North America, predominantly involving male patients. There's a need for more data on women, diverse ethnic groups, and outcomes in lower-income settings.
What about practical issues like measurement or technology?
Yes, several key areas. Measurement consistency for ultrasound remains unresolved. There's still no universal standard for exactly how to place the calipers, which impacts screening, surveillance, and threshold decisions. Technology evaluation is another big one. The need for rigorous, independent, long-term evaluation of new EVAR devices and techniques before widespread adoption is stressed repeatedly, citing the Nelix example. They even suggest future research into automated active surveillance systems for implanted devices.
And the impact on surgical training.
That's a major concern raised. With the shift towards EVAR for many infrarenal AAAs, how do trainees and even established surgeons acquire and maintain proficiency in complex open aortic surgery? The guidelines ponder whether OSR should be increasingly centralized in high-volume centers and whether simulation training can adequately compensate for reduced real-world exposure. It's a critical question for the future workforce. Other areas include improving radiation safety protocols for complex EVAR, refining medical management targets like specific LDL goals, getting better long-term data on FEVAR-BR outcomes and cost-effectiveness, and fostering more collaboration for research into rare aneurysm conditions like mycotic or genetic AAAs.
So a lot still to learn. Okay, let's try and synthesize this massive amount of detail. We've simulated a pretty intense VIVA based on the ESVS 2024 guidelines. For everyone listening, what are the absolute must-know bottom line takeaways, the crib sheet points?
Okay, let's boil it down. These are the critical points for managing AAA, effectively based on the 2024 guidelines. Thresholds for elective repair. Remember the key numbers. For men, repair generally considered at 5.5 centimeters. For women, repair generally considered at 5.0 centimeters. For women, also repair if growth once every year or if symptomatic.
Right, thresholds are key.
Then the choice of repair for elective cases.
Repair choice, elective. EVAR is generally preferred if the anatomy is suitable, especially if life expectancy might be less than around 10 years. Lower short-term risk. Open repair, OSR, is favored in younger fit patients needing durability, or if anatomy is unsuitable for EVAR, or in connective tissue disease.
And if it's ruptured.
Ruptured AAA, RAA. EVAR is the preferred treatment if it's anatomically feasible. Strong Class 1, Level A evidence shows better survival compared to emergency open repair. Don't withhold treatment based solely on age or risk scores. Decisions should be individualized.
Okay. Key complications to watch for and manage. Key complications. Type 1 endoleak, AVR. Urgent correction needed due to high rupture risk. Type 2 endoleak, EVAR. Usually surveillance, but intervene if the aneurysm sac grows or causes symptoms. Abdominal compartment syndrome, ACS. If non-surgical measures fail, decompressive laparotomy is the definitive treatment.
Surveillance after repair.
Surveillance. Post-EVR, lifelong imaging follow-up is recommended, CTA or DUS. Post-OSR. Less intensive, no routine imaging recommended, but clinical review remains important.
And finally, those special scenarios.
Special considerations. Women. Lower repair threshold, 5.0 centimeters, higher rupture risk, infected, mycotic, AAA, needs prompt surgical excision repair irrespective of size, plus long-term antibiotics, multidisciplinary approach, concomitant iliac aneurysm, aim to preserve at least one internal iliac artery, genetic syndromes, for example, VEDS, require genetic evaluation and specialized care, for example, celiprolol for VEDS, new technologies. Use with caution, ideally within clinical trials until proven safe and durable long-term.
Fantastic summary. What a deep dive that was. From nailing the diagnosis and assessment, through weighing complex treatment options, managing complications, or providing long-term care, it's really clear that managing abdominal aortoiliac aneurysms is this intricate blend of applying the evidence, using expert judgment, and crucially involving the patient.
It absolutely is. And the fact that these guidelines are constantly being updated, with hundreds of new references incorporated just since 2019, it just underscores that this is a dynamic field. Our pursuit of better, safer outcomes for patients with AAA is definitely an ongoing process. There's always more to learn and refine.
So here's a final thought for you, our listeners, to perhaps mull over. As endovascular technology keeps advancing, becoming less invasive, arguably more accessible, how is that going to continue changing the very definition of what constitutes surgical skill in the vascular specialty?
That's a really profound question. Does mastery shift from complex open dissection to intricate wire and catheter skills, image interpretation, device selection? Or does it mean open skills become even more specialized, reserved for the most complex salvage cases?
And what does that mean for how we train the next generation of vascular surgeons? Something to think about.
Definitely food for thought. The guidelines touch on it, but the full impact is still unfolding.
A deep question indeed for a deep dive. Thank you so much for joining us on this exploration of the ESVS 2024 AAA guidelines. We hope you feel a bit more well-informed, maybe a bit more prepared for that next challenging case, or even that VIVA. Until next time, keep digging for those nuggets of knowledge.